A very good evening, everyone. I am Dr. M. Shia Jaiswal, currently pursuing PhD in oral and maxillofacial surgery from Busan National University, South Korea, and I'm the host for today's session. Today we have Dr. Reena Yadav from India with us. She has completed her BDS, followed by MDS in oral and maxillofacial surgery from B.R. Ambedkar College, Agra, India. Later, she completed her senior residency from Ramakrishna Mission Hospital and fellowship in head and neck from Dharamshila Hospital, Delhi. She also worked as a consultant in IAOMS for about 2 years, and currently she's working as a consultant in Orbit Super Speciality Healthcare Private Limited, RMS Hospital, and Northern Care Hospital. Her interest for oral reconstruction pulled her towards Zygomatic implants, and later she got affiliated to QuickDent implants.
Okay, thank you, Jaiswal, Dr. Jaiswal, for such beautiful introduction. And to everybody, very good evening. Thank you for your time. Today, I would be starting with a very usual and very common immediate loading with zygoma implants. It is not only included in the atrophic maxillas, but how do I'm using this zygoma? It's actually a blessing for me in my field, which I'm using it regularly. And thanks to QuickDent, which they have provided a tremendous support and help from them. Thank you. I think I'll be starting sharing my screen. Dr. Jaiswal, just let me know if you are able to see.
Yeah.
Is it available?
Yes, it's visible.
Okay, so I'll just start. The zygoma has started my journey. I started with restoring such maxillectomy cases where I come to know that only restoring with the graft is not important. It is actually the function, the chewing, the swallowing, the nutrition, and the quality of life is so important in a patient who has no teeth and who has teeth. So this is one more case. So this is how I started my journey. This is post giant cell tumor. So we started with COVID. As you can see, this is a beautiful bone that we have. As we do immediate cases, we usually try to get nasal spine, zygoma bone, and pterygoid in the maxilla so that we can restore this occlusion, especially your prosthesis, using such bone that does not cause any, resorption in future. So you can see some of my clinical cases I've mentioned here. This is how we raise the flap. This is a post-op OPG with the help of pterygoid zygoma and an anterior implant. It's a QuickDent implant, TPRs and zygomas and pterygoids which we are using. A beautiful implant is just a sharpening effect of the implant is helping all like surgeons like me to be rapid, aggressive and corrective and delivering an accurate prosthesis which patient needs, especially to get its quality of life of chewing. So this is one of the video which I wanted to share. If you do a normal case, you have an alveolar support, but in this case, since maxilla is missing, so placing the drill and getting a prosthetic correction is very important. So as doing so many of zygomas, I'll be mentioning about my article also. I realized that placing implant is easy, but you have to plan your entire prosthesis. So it's basically vice versa. Though I'm a surgeon, I'll support first prosthetic corrections of the maxilla and mandible, and later on correcting it with the help of implants, planning your zygomas, pterygoids accordingly. So this is how we place the implant. And this is how we started the journey of this. I'm almost 5 to 6 years with QuickDent, and we did a lot of zygomas together. And the main important part is the rough surface is inside the bone, a zygoma bone, and the polished surface is outside. The placing of implant is very important because it has to have prosthetic corrections, as you can see here. It has to match your palatal aspect so that it's not placed too palatally or too buccally, giving you a bulky prosthesis. So this is a post-op OPG of one more bilateral maxillectomy case. As you can see, there is a prosthesis delivered to such patient. It was though a removable prosthesis, but later on we helped them to give the prosthesis final. And also it has helped him not only to improve his chewing, but also his speech has been improved because of the fistula, which has causing a change in his voice, especially his pronunciations. So it's a journey which not only helps in maxillectomies, but also in atrophic jaws, restoring those maxillas where patients has been wandering from one patient to other patient. Uh, and we have been restoring it since then. It's a very old concept actually. As you can see, I have done a small diagrammatic presentation I'm trying to show. This is the beautiful bone which we use, which has no resorption. This is your pterygoid plates where we place your pterygoid implants, and this is your nasal floor. So using all these three bones which are non-resorbable, your incision line is as such, we reflect only this area, the zygomatic muscle tubercle where we have masseter muscle attachment. I'm trying to show a cross section too in this side. And when you see PNS view of this patient or the diagram, you can actually see we use this bone. So this is a very thick bone which is been blessed by every patient, though it is diagrammatically and radiologically different in each patient. But yes, this bone is as such that if you do anchorage here, your other implants may fail, but zygoma is very rare which fails. So I'm trying to just show a small video to show the anatomical area if you can see. This is the beautiful bone, which is reddish pink in color. As you can see, there is a muscle attachment. So this entire area has been reflected. You only see a whitest structure of masseter muscle when you reflect, which is this area. The entire area is retracted inside your Langenbach. Going more further, if I take just the zygomatic bone, if we cut through it, you can see this is the orbital rim. The myth about the implants going into the orbit is very rare, and it is false, I would say, because it's a very thick rim. To cross this, it requires a tremendous force too. So when we place quad zygoma, this is the area which we use for placing two implants in your premolar or canine region. So just trying to show. So this in this area, you have your maxillary sinus. If you delete the maxillary sinus, you see the thickness of the bone, how beautifully it is presented in atrophic maxillary patients, zygoma. So as we all know, the classification pre-maxillary, that is canine to canine, two premolars, and the posterior molars, who are the occlusion bosses. So there are a lot of classifications which has been mentioned. You know, there is techniques like maxillary, extra maxillary or intramaxillary, transmaxillary. So it always depends on the two bone. One is your zygoma bone, and the other is your alveolar crest on which your zygoma implant lies. As you can see, this picture has been taken from an article. So as you can see, I'm trying to mimic the what structures we are here. So usually when we get patients who has severe atrophic maxillas where you cannot place your conventional implants or cortical implants in the anterior, or a combination of same in your premolars and molar region. So we use usually type 3 and type 4, which is usually extra maxillary. So these are the instruments which I usually use. It's a zygomatic compact kit by QuickDent. It has entry points, bars, and your drills for placing your zygomatic implants along with the path guide. So my simple for surgery, I do only a few steps. It's like good reflection so that I'm able to just show here. If you see, we reflect, this is the buccal pad fat. So if you have a bulky patient, so you may tear the periosteum too. And anterior, we don't go. This is your infraorbital nerve. So we try to avoid going through this. So this is your zygomatic area. This is the masseter attachment, which I showed you. And this curve decides whether your implant will be intrasinus or extrasinus. So of course, the entry point we make on the zygomatic bone, and parallel to marking your 5, here is your first premolar. And then we try to connect these two points together. It's complete mathematical thing. We did a slotting sinus preparation, mostly with good maxillary sinuses. We have this, but usually the more atrophic it is, we don't have this membrane getting irritated. So we have dedicated burr for it. Now we're going to start with drilling with the zygomatic bone to create a pathway. So this is how we measure There is a sinus perforation. This is how we do measurement. We always try to measure the zygomatic implant length towards the crest so that a prosthetic corrections is important. If it's too palatally, if I take this third or fourth marking in between, if I place a length of about 45 or 47, so my prosthetically, the prosthetic prosthodontist will definitely come and fight with me for getting his teeth giving in the more palatal aspect. If I raise it too buccally, of course my forces will be present by all the tissues around it. So it has to be anatomically as well as occlusally as well as prosthetically delivering the equal forces which we require for mastications. So this is how we place the implant. While placing the implant, I make sure my one hand is near the orbital area so that I get a feel while drilling and while placing my zygomatic implant. So you can see how beautifully I'm getting the torque. I'm trying to get into the position where I can prosthetically correct it and my multi-unit will be seated at the occlusal level. So these are cortical implants, the cortical zygomatic implant. This rough surface area, I'm so sorry, I just. So this is the rough surface area which is seated in your bone, and this is the shaft. So it's basically more hygienic biometrically also important that you have good resistance to all the forces. The polished surface of the zygoma is also having pathological disturbance, which is avoided while seepage or anything like that. So basically, when you do immediate loading, it is important that you make sure that you load your implants immediately using a multi-unit. If you don't, then you have to place a cover screw. Don't use your multi-unit and wait for 2 to 3 months to load your prosthesis. It causes failure to your zygomatic implants. This is one of the very usual when I go for consultations. I have a question saying that the implant went into the orbital area, but it is very rare and only 2021 in Italy. I've just seen this article. I haven't encountered yet. What I guess is the entry point must have been missed or it slipped. So it went on that side, but it's too resistance to get it. These are my some of the cases. As you can see, my maxillary sinus has come down. The pterygoid bone is beautiful here. I can get a canine preeminence more because of the extractions and the RCT. We had a brittle bone which got fractured. And so we planned for, this is another CBCT of the same patient. So we placed quad zygoma for such patient. As you can see, this is the edentulous alveolar ridge where I've prepared my five and my sinus slotting has been done. This is how I've placed my implant. Equal parallelism and of course the AP spread. Canine, the anterior is covered by 3 to 3 and the posterior 5 helps me to give me 6. So my prosthesis tool 6 to 6 will be there. This is a quad zygoma case which I'm presenting. The closure. Once the tissue is closed and it is respected equally while closure, there is less chances of microseepage or recession of these kind of tissues which we give the split at the zygomatic area. So you can see how closure has been watertight. This is my OPG post-op cross sections. Another similar case with quadzygoma and pterygoid. Basically, if you do over engineering, it's important because over the time when the one of the implant fail, you can help still have these prosthesis placed. Just removing that implant will help you to get your prosthesis back. This is some another combination which I have placed. A unilateral, again a unilateral case. This is my experience in past 5 years, over more than 200 zygomas with combination techniques, including quad and single zygomas. So this beautiful gentleman, we have restored him. Given he's just 37 years old, maybe because of some periodontally lost, beautiful smile has been delivered. We have not only delivered a zygomatic implant to him, beautiful prosthesis smile. He has gained more than 10 kgs of his weight because of good eating and chewing. Another gentleman, a gutka pan chewer, who wanted his teeth to be firm and he has no bones. So we have used quad zygoma for the same patient. This is how we have restored his prosthesis. So I know this today's talk is more into the zygomatic benefits and all, but when you do a surgery, we often come across a lot of complications around. So this is over so many years I'm doing Zygoma. So I've just jotted some points like pre-operative evaluation, operative evaluation, and post-operative, and of course follow-ups. Follow-up play a very important role in any implants or any surgical procedure, even if you do a routine dental procedures. So how do I go about my Zygoma cases? So systemically evaluation is very important, especially for diabetic cases. So the number one point I'll say when you go for any zygomatic case, first of all, you have to take a history of sinusitis, including which you have to evaluate the CBCT and OPG so that there is no sign of any sinusitis in the beginning. Mostly patients with diabetic who are prolonged or who are under medications usually have shooting up diabetes, which causes chaos in the healing phase. So you have to take your consultations with physicians. Steam and pre-antibiotics are very important. Then in operative, how well you are prepared with your implant sizes, with your implant, with your releasing, how will you control your bleeding? Though if you reflect and respect the tissue very correctly, you may not encounter anything. Also, irrigation is very important. A cold coolant is very important. Of course, when you place your implants, I've been stressing since the beginning, the prosthesis position is very important, and of course, your flap closure. So, in the beginning, when you do implants or when you want to, or any consultant coming to you, you must know that there are few complications which may happen, and these complications are not much as life threatening, but this is something if we acknowledge together, it is problem solving, and over the weeks it gets solved. So I'll just like to get some highlights over this. Swelling, which is very common, you can add some of your anti-inflammatory and steroids to it. Sometimes diabetic patients causes nuisance, but it's still, if you add 2 days of steroids, it may not cause any problem. Another, I've seen swelling. So if you can see maxillary sinus, we always have a myth that this is the alveolar bone, this is your zygomatic area, and we just drill and we finish it off. No, the bone debris coming in, usually a minute particles do get inside the maxillary sinuses, and these are the turbinates which are present, and it causes inflammation, and due to which the congestion, it leads to delayed in the recovery or healing of this area. So whenever you drill accurately and you have to perforate this area, but we don't over perforate. Whenever we try to get a zygoma implant size, it's always under this area. We do perforate the second cortex, but we are at the second cortex. We don't cross the second cortex. So whatever debris here contacting to your soft tissue causes this kind of swelling. If not encountered early, it may land into failure of your implant. This is another case. This gentleman had a HbA1c 8 when we were operating him, and due to some wedding or something function at his house, his HbA1c shooted to 12. And as you can see, this is the perforation which I was talking in previous slide. When we put a drilling, we do perforate on this side, and the soft tissue either communicating inside this slot or this entry point, it usually causes inflammation and swelling at the area. If you tackle it correctly, then it gets solved. If not, then it leads to implant failure. So another case where we had done over engineering the two quad zygoma along with the pterygoids, but due to that same thing, I have removed one zygoma, and we with this the patient is able to eat, and prosthetically she is absolutely fine. We do take her follow up in every 6 to 8 months. This is another case. It's just a highlight. We have not placed this implant. This is very initial state when I started. As you can see, there is an entire communication, oral communication. This is your oral part. This is your maxillary sinus. This is your zygomatic bone. So it was so infective that I could not get it inside. As you can see, the other side we were able to place, but after 6 months we did this case and we were able to deliver the zygomatic implants to the patient. Another case, there's a communication. So you have to see whether both equal side you have a tissue or not. If not, then you can use buccal pad to close. Another case, communication. So how do you deal? That is important because exposure to sinusitis causes a lot of difficulties. There is continuously plurine discharge in the patient, continually accompanying of change in the taste. As you can see, I've tried to explain the same thing. If this gets inflamed and the entire mucosal lining gets inflamed, so this causes congestion, and due to which there is a inflammation and infection at the maxillary sinus, causing the, if this little bit of shaft is exposed, it may affect the entire implant. Another case, as I was talking, if you don't close it correctly, the tissue shrinks. But due to the shaft being polished, the only thing is the patient has to take a good care while hygiening, and they complain of exposed implant. But as such, they don't have this much problem, as you can see some cases out here. So as I was since beginning, I was telling, so placing zygoma implants is very easy, but planning the processes and which type of processes to be given is very important. Whether you are only doing a maxillary area or you're also completing your full arch, upper and lower, the placing of implant into palatally causes bulky of processes. Tongue, if patient is macroglossic, it causes more problems. Another case where it was not planned correctly. So conclusion is you have to go thorough with any kind of dental implants you're doing. You have to sit thoroughly with your CBCT plan, take help of your, of course, your colleagues, your surgeons, your seniors, and do ahead and go ahead with the case. But trust me, if your implant planning is good, your surgical procedure is minimum, and your complication is being planned, and you know what to do ahead. So this is my article which was published in 2024. We have done a 60 patient for about 140 zygoma implants where I lost 2 patients in follow-up, but overall I got 99% of the success rate if I exclude those patients. There were a combination of quad zygoma, one anterior conventional implant, and other were single zygomas or one side two zygomas we were placing together. This is my very first patient when I started with zygoma in dentistry for atrophic maxillas. So I would say it's a boon. It's actually very thankful to the dentistry where we have evolved the zygomatic implants like a routine procedure, and it's been done every day in majority of clinics. So these were the past 6 months I've delivered so many smiles, and I'm happy that I was able to give them, and whatever surgical skill I had because of QuickDent zygoma implants, making them happy. So this is me, Dr. Reena, and thank you so much for this platform, Dentist Channel Online. Thank you so much for coming up with this webinar and giving me an opportunity. So yes, over to you, Dr. Jaiswal.
Thank you so much, Dr. Reena, for such an insightful, like short yet informative and very insightful webinar session. So now it's a Q&A time. So if you have any questions, so you may put your questions in Q&A box. So let me see that there is one question from
Okay.
Kaustov Kar. That zygomatic implant go to orbit, so management protocol.
See, so far I've been doing it doesn't go to zygomatic this thing. If it goes, your patient will start watering of the eyes. Suddenly the patient will just jerk it when you put such a high torquing drill to the zygomatic bone. So it is only when your entry point, that is I showed you, then the zygoma, when you do your entry point, it gets missed, then only it is the chances that your angulation changes. But it's always important your entry point and your five, where you're placing your ending your zygoma on your alveolar bone, at that line has to be correct. And the slipping is if you're doing implants regularly, there is no slippage chances. It's only when there is an very thin bone you've been pressing. It's all about the angulation goal. So far I've not encountered. Even if it encountered, the patient would may get an injury to your orbital wall, and the fat which is present there, swelling, hematoma, hematomal, conjunctival, watering of the eye, and what may not. So I haven't encountered such.
Okay. Uh, there is another question. After OMFS, I have to qualify AOMSI and directly admission onco fellowship. Kindly explain future option. I am already done palliative medicine fellowship, so get advantage for that.
I think it's not a question to be placed here. You
Yeah,
can put
sure.
me on LinkedIn.
And next question is that what should be the upper limit of HbA1c up to which Jagoma implant can be undertaken?
See, any surgical procedure we usually do till 8. It's still recommended you have to do any surgical procedures until unless it's emergency in case of impactions. But zygomatic is not an emergency procedure. When you plan an implant, it is obviously a planned procedure, elective procedure. So you have to take HbA1c to 8. In some cases like chronic diabetes who cannot go below 10, so you have to make sure that physician has been involved and either the patient is shifted to insulin, so your span of monitoring will be increased. So if you place some for example, if your HbA1c is 10, if your physician has given you go ahead, so you have to and take a consent to the patient, and you have to do a thorough follow up for next 7 to 10 days till the time you're delivering the processes. Your irrigation, your watertight sutures has to be monitored and examined by you in every follow up till the time you deliver. Post delivery, you can definitely get a OPG done, check, or else CBCT is the best, so that you know whether maxillary sinusitis has been any debris or not. And the best way to check clinically is patient will start complaining you about the nasal congestion. So that is one. So usually post pacing the zygoma, I ask my patients to start with Otrivine nasal drop and steam inhalation, so that if any debris has been left by me, it will be corrected. And while placing my zygomatic implant, my drills has good copious irrigation. In external irrigation also I do, using 20 ml of syringe with RL.
Okay, and next question is which company implant preferred option? How much you charge for complete arch procedure? So this complete arch procedure, you can leave it because it's personal question. It's like if you are residing in rural area or urban area, it depends on that. But yeah, which company implant preferred option? So tell me which company implant you use
So I
generally.
am using it's like usually not. I'm using QuickDent. I'm a big fan of QuickDent. Since 3.5 years, I've been placing this, and I have touchwood achieved a good maxillectomy, post maxillectomy. Not only oncology. See, post radiation, it's difficult to deliver any kind of implants. But I know when patient is on stage 1 or it's giant cell tumor, so I do take the options of zygoma bones. So I think QuickDent is the best I'm using.
Okay. And I think this is the last question from Tathagat Singh. Line of treatment if there is a failure of zygomatic implant, wait for some time and redo, or need to think of other treatment modality.
See, basically, when you do a single zygoma implants, you do when you have no options. There is always a graft options that you have to plan. It's obviously customized to every patient, every individual. So if it fails, you have to know the reason of failure. So if it's sinusitis, yes, of course, after 3 to 6 months, you can wait and re-enter. Meanwhile, you have to give a very light-weighted prosthesis and ask the patient simultaneously to have soft diets, uh, not very firm diets which may hamper your unilateral chewing, because one side patient is comfortable, the other side patient may land into causing a cross occlusion stability. So that you can do, of course. And third is, if you feel that how you counsel the patient, that is important. After failure 3 to 6 months, I have placed one of the implants which I showed you also. It was 6 months back, but it was because of the maxillary sinusitis pathology in the sense sinusitis, which had a huge sinus thickening and lining about 3 centimeter.
Okay, Dr. Reena, next question is PRP procedure required for abutment-based placement.
No, not required. If you really give a good releasing incision, your releasing incision has to be in the vestibular area. And if you're doing a full mouth, so you can raise your flaps in 6 to 6. And you can do, but you have to again have lots of armamentarium. And zygoma has eased. I think zygoma has is being launched and it's being used thoroughly because of avoiding all the PRP procedures and buccal pad fat. Yeah, you can of course use, if you are good with perio thing, you can of course use it, but I don't prefer doing it. If you give a good releasing incision, your it directly helps in closure, primary closure basically, because you remove the sinus slotting and you remove the bulge of the alveolar ridge at that time.
Okay. Next question is from Kostov Kar. How to select cases that it is zygomatic implant or corticobasal implant?
See, I told you, if in lay, very lay, as a friend, if I tell you, so you have to think if whether you are able to place your implant at 4 and 5 region or not. So that's your cross sections, which is helping. So if you're going for a tilt, see, immediate loading is all about tilt implants concept, and it's obviously every time we place cortical engagement is important for your long term, because alveolar ridge do resorbs, and we all have learned in our dentistry that 1 mm every year it resorbs, and we've seen patients too. So if you get a good length of about like 12 or 14, so you can of course go for cortical implants. And if you want to place zygoma, so you have to see the region and how maxillary sinus has been reside to your alveolar ridge. So if you're not able to place at 4 5, sometimes you see that on the OPG or CT scan you're able to do it, but when you start drilling, there is D4 or D3 very soft bone which this make you immediate decide of your zygomatic bone. If you have already planned it, so you should always have a backup of zygomatic implant if you're planning a full mouth implant.
Yes. So next question is kindly suggest best book for zygomatic implant guidance.
I think articles are the best book. I cannot just tell you the simple one book, but I think if you go to thorough article and publications, then it is very best thing to read.
Next question is from Navira Nairin Khalid. In cases where a direct sinus lift is not feasible and we need to wait for 9 months for placing an implant, can zygomatic implant be considered a viable alternative?
A single zygoma cannot be placed as you place your conventional implants. No, if you have an arch of about like 3 to 5 something missing, 3 5 6 missing, or 4 5 6 missing, then you can do a combo of zygomatic and anterior implant and a pterygoid. But single zygoma, I won't recommend. I have not tried also. If you want, you have to go for delayed. Some see, if you have zygoma, you cannot just push in every cases. It has to be justified to you and your patient.
Yeah. Next question is from Dr. Kostovkar. If length is 16 millimeters, so surely zygomatic implant on the basis of D3 and D4 bone.
No, that is how is your placement of your maxillary sinus in your 4 and 5. See, when you do a full mouth, you need to place at least 6 to 8 implants. If you're doing tilt implants, so 3 on each side is required. So canine, usually they say it's canine, premolars, and 8. So you have to decide whether you're getting a good bone in your 4 5 6 region. If not, then you have to go for zygoma.
Okay. Next question is that rubber dam placement required in between abutment base and implant.
No, I don't place.
Okay, so this was all about today's webinar session. Thank you so much, Dr. Reena, for joining with us and for, sharing your valuable knowledge and for sharing your case studies or whatever cases you have done in your clinic. So I think the takeaway note can be this zygomatic implant. It offers a reliable and minimally invasive alternative to extensive grafting procedure, making full arch rehabilitation possible even in severely resorbed cases, right? So I hope you have already shared everything. And yes, thank you so much once again to all the attendees for joining with us and for listening to this webinar session. Thank you, Dr. Reena, once again.
Thank you, Dr. Jaiswal. All the best. Thank you, everyone. Thank you. All the best.
Okay, have a nice day. Bye.
Bye bye.